started.
All right. Hi, everyone. Good evening. Wow, thank you all so much for coming out here. You know, what a group, what a crowd. So big welcome. My name is Van Ann, and I'm one of the volunteers for this event, along with Sophia, Christy, and Lakshmi. So we're really excited to have you join our Women's Health event today, which is part of the Digital Health track with the MIT Club of Northern California. So a little bit about the MIT Northern California Club. Its mission is to connect and further the well-being of MIT alumni as well as the local community through various different tracks of programming, and we're entirely volunteer run and led. So this is all on our own time. So for the Digital Health track, this is the last event of the academic year. We'll take a summer break, and then we'll be back in the fall, and we'll actually be continuing the Women's Health series with an AI in fitness and sports tech event. So look forward to that. But for today's event, we're hoping that all of you come away with 3 things. So one is to be empowered with really valuable health information, either for yourself or for your loved ones. 2, to understand the systemic importance of the women's health space. And 3, be inspired by the entrepreneurship generally and in women's health by these amazing panelists you'll hear from. So in terms of structure, we'll have 60 minutes of panel discussion and Q&A, and we're also going to be crowdsourcing questions and doing upvoting throughout the discussion, which Christy, the moderator, will talk through in a bit. And then afterwards, you're welcome to linger a little bit to chit chat, connect with each other, and also visit our community table over that way. So yeah, all right. I am now very excited to hand it over to Christy, who will kick things off.
Yes, thank you so much, Van Ann. I'm Christy. It's a sheer delight to be with you here this evening. You could have chosen to be anywhere this evening, and you chose to be here. And we're hoping to make a difference not only in the community, but also the support for women's health. So this is one of many sessions, and we need your support and your help. So thank you so much from the bottom of our hearts for being here. You might have seen some QR codes at the front of your chairs. So those are purposeful and intentional. It's also to my right, no, my left, your right, pardon. Can't think backwards, mirror imaging here. And that's tied to our AI companion. So the goal with that is for this to be really interactive and conversational, not only with the panelists, but with the audience. So if you feel inspired to ask a question, let those inspirations lead you to scanning your QR codes, and you'll see the questions reflected up here. And then we have folks monitoring that, so more than 2 upvotes. Basically call attention to your question, and then you can learn more about our panelists, their LinkedIn profile, Twitter, and all those social media avenues. So without further delay, now that we have our QR codes, let's set the stage. Our esteemed panelists span a variety of women's health topics, from reproductive health, fertility, hormonal health, and let it be known they are experts in their field. There are 3 statistics that I really want you to take home with you. The first is, when it comes to women's health, females have been underrepresented in clinical studies, despite the fact that we are now the majority, greater than 50%. So that's really important to keep in mind. Our participation in clinical studies has been, as of a Harvard study in 2022, about on average 41%. Now, I think tens of years ago, it's below 30%, right? So not too favorable in access to data. The second is, when it comes to diseases impacting women, we're underfunded despite the burden. So we don't have data, we're underfunded. The third is actually kind of the word on the street in the venture capitalist world is that women's health was a small market. Again, let it be known, we make up a majority of the population. So change needs to happen, and that change has happened of recent. 3 items to call to your attention. The first is ARPA-H has really called for a sprint in women's health. The second is an executive order. The request was, I think, several tens of billions, and what was approved was 100 million. So really a fraction. So change is imminent. Is it what's necessary? Maybe. Is it sufficient? Absolutely not. So the females on this panel, quite frankly, have succeeded when the odds have not been in their favor, from the lack of data, the need for innovation, and the lack of funding. I encourage you all to review the McKinsey report that came out, actually before the executive order, which called attention to the fact that women's health is a $1 trillion market opportunity. To influence outcomes, I would argue we should change that verbiage, is to change lives. Again, for female, that is the majority. Obviously including all genders, but highlighting that we've been at a deficit for far too long. So without further delay, let's hear from our esteemed panelists. Let them share their stories, their journeys, with the odds not in their favor, and talk about the innovations that they have brought to bear and that they're bringing to bear. Sophia, would you like to start?
Sure, so we're doing intros?
Yes, please, intros.
Hi, I'm Dr. Sophia Yen, being Asian descent. My mom said, claim all your titles. So everyone in the room, claim all your titles, let's have some fun. We're all very well educated in this room. Obviously went to MIT. I like to say I'm the only founder you're gonna see with a condom bag, a uterus necklace, and a beaver ring. For the non-MIT people, the beaver ring is the MIT ring. So, because we are the natural engineers. And Pandia Health, I'm a clinical associate professor at Stanford for identification purposes only. Anything I say does not reflect Stanford. But I started the company when I was giving a talk to a bunch of physicians, why don't women take their birth control? And one of the top reasons was, didn't have it in their hand. And my friend Perlini and I looked at each other like, well, you could solve this. We will just ship women birth control and keep shipping it until they tell us to stop. And then 2 months before the prescription runs out, please see your doctor. 1 month, please see your doctor. 1 week, please see your doctor now. And then we ran ads, free birth control delivery. 60% of the people who responded didn't have prescription. As an entrepreneur, I don't want to run ads where 60% of my ads were useless. And as a doctor, I could write prescriptions. Thus, Pandia Health was born. If you need a prescription, then our physicians can write it. If you have a prescription, you have insurance, thanks to the Affordable Care Act, Obama, Biden, any FDA-approved birth control, no copay, no deductible, AKA free. And so we started with birth control. We added acne because I'm adolescent medicine, sex, drugs, rock and roll, a little acne, some sports medicine. I can do acne in my sleep. And then I hit menopause, and all my friends are like, menopause. And I'm like, yes. I found the best treatment for me, and I will share it with all of you. Along in our journey, we were lucky to pick up, there's only 1,300 Menopause Society certified practitioners in the entire country. And 51% of the population will go through menopause unless they die before them, which we hope not, at 50. And we've got 2 of them. Ours both are OB-GYN, and they both have 20 plus years in menopause. And they're leading our 100% physician team in our menopause practice. We currently can prescribe in 16 states, and we can deliver to all 50, and we're raising. So if you know any investors, send them our way. Great.
Hello everyone, I'm Sophia. I'm the CEO and co-founder of Mira. I'm not from MIT, but I graduated from Columbia with biomedical engineering and then MBA from Cornell. And then I'm really glad to be here. Also, I'm an MIT alum. So I started a company called Mira. So what we do is we track the hormone for women. So we track fertility hormones like LH, estrogen, progesterone, FSH. And what we do is to help people to understand their hormone, and if they're trying to conceive, and if they know when's the fertile window, when's ovulation, if they have PCOS, the hormone imbalances, they got the better understanding of their hormonal health. And we have been growing really fast in the past few years, and we went directly to consumer at the beginning, and it was the really huge success. Actually, it was really a surprise to me, how many women in this country really are eager to know their health, their hormonal health, and to understand their cycle, understand their body. So there was no such concept or very good service like that before. Usually, if you can't get pregnant, you go to talk with OBGYN, maybe they're gonna do one-time hormone assessment for you, but that's not like a complete panel, or not like a complete continuous tracking to really tell you what to do. So recently we moved into telehealth as well. So our users really want to see that after hormone testing, what can they do? And we also collected so much data. We have 13 million hormonal data from our consumers, and we're doing a lot of efforts to trying to understand the hormonal health. And for women, for for our business for sure, but also for research and for some long-term goal as well. So really glad to be here.
Hi, that was really interesting. So I guess for the women who are younger, you guys are very lucky. When I was younger, I wish I had access to services that Sophia and Sophia are providing. So I think hopefully, I think that's the spirit that we're really making, making changes, making women's lives better, and also not just for women, all the people around them as well. My name is Mylene Yao. I'm co-founder and CEO at Univfy. Our company uses AI and machine learning to build prediction models to help people who are looking at IVF and other fertility treatment options to find out what are their chances to have a baby if they pursue IVF. And I don't know if you guys know this, about 10 million women or couples in this country could benefit from using IVF to have a family if they could have access to that. But it's vastly underutilized. This is a treatment that's been around for over 4 decades now, highly successful, very safe, but is about only 3% of people needing it are using it or accessing it today. Of course, there are many barriers. Financial barrier is one, but also not understanding the benefits, not understanding what's the chance that this can help me to have a baby, and a lot of just misinformation. So what we're doing is really, we're data driven. We want to use, we are using data and AI to help women understand what is my chance of having a baby based on my healthcare data, my partner's data, and validate it for this particular fertility clinic so that they can go into this decision making fully informed. We're working with fertility centers in the US, UK, and Europe, and we're also looking to expand to APAC as well. And ultimately, we already have a way to make model accuracy to help make this treatment more affordable, to expand access. And we're also now looking at helping some countries to make population sustainability possible through a wider use of IVF or a wiser way to spend their resources. So those are the things that we do, and it's a lot of fun. Prior to Univfy, I was faculty at Stanford, and this started, the technology started as an academic invention at Stanford that we're now bringing to countries worldwide. So, and I'd love to, if you have suggestions and interest in how, we can help to, bring this health technology to kind of globally and to help more countries on a public and social level, I'm very, very interested. Would love to, chat after.
Oh, sorry, I have one here. Fabulous. So as we heard about a variety of innovations that you elaborated so seamlessly, right? All these founders, wearing my engineering hat, when we think about innovation, it's not just me, we think about the S-curve of innovation, right? There's research and development, then there's a little bit of more adoption, and then there's mass adoption, right? So when you think about producing products, how do you get to that mass adoption? A ton of engineering, a ton of R&D. Could you shed light on, there's a lot of hype and a variety of technologies. Which technologies did you foresee to be helpful to your company? And which innovations are you thinking about now to either implement into your company for your product or have already implemented? Whoever would like to go first.
Yeah, it's a great question. So it's actually a very difficult decision. If you think, okay, now I want to start a company and which product might be working. So I think you face some situation, either you don't have any idea or you have too many ideas, so all things gonna work, and you just don't know how to pick that. I think the requirement here is that you really have to understand this industry and understand the pain points. So whatever you do, like for example, if you want to develop something for the healthcare system, you really have to understand, how the healthcare system works. Our healthcare system has this patient, provider, payer is kind of relationship over there, and really think about what kind of business model will be the feasible to go. So sometimes you have a great technology, but how the market really can adopt. It has to be something the market is about to be ready to accept. It's not something too new. It's not something like a too repetitive, like a Me Too product, which is not gonna have value proposition. But at the same time, you have multiple players in this industry. So how do you position them together so they will push for your product to be adopted? So when we started Mira, was actually, I didn't know any of this. And we went for you can call it like an easy route, but it's actually not easy either. So we just thought about maybe we should directly go to a consumer. And that's based on some observation, because I was about 30, a little bit over 30 years old that time. I had this much education, and all my friends, my social circle was really similar to me. Nobody had a child that was thinking even about to get married or having a child before 30 years old. So then after 30, it's like, yes, I'm trying to conceive. Okay, and I feel like I know nothing about my cycle. It should be very easy, but then you don't get pregnant, and then say, okay, so let's get some OPK, like an ovulation predictor kit from Amazon, and says 2 line, 1 line, 1 line, 2 line, sometimes 1.5 line. I don't understand what is that, right? I say, okay, seriously, like a darker line, thinner line, dark enough, thin enough, and I go to see some my OBGYN, and they did some exam and did some blood drawing, and say, yes, you're okay, your husband is fine, and just unlucky, continue to try. But how does this help me? Because I was eager, and I need to get pregnant. I have a goal, right? I cannot be pregnant forever. So I feel like, I have seen so many cases around me like that. And unfortunately, some of them have to go through IVF. I think that's a great tool, but at the same time, do they have to go through IVF? How long do I need to wait? Is it half a year, 1 year? I feel like, that situation is very ambiguous. And also emotionally super draining because you don't have a control. I'm just doing the same thing again and again. I don't know if that's gonna work. So then I was thinking like maybe we should bring more clarity into women's health. And I feel like our consumers, they already have this understanding, they're pulling for this. If we give them more data, how about that? And if we give them some interpretation about the data, it has to be accurate but affordable because you're going to consumer, and easy to understand, easy to use. Can we change this? Can we make that a little bit better? It was actually, if you think about this, it was like a just very small value proposition. They say, okay, now, because what we do here is that we give everyone quantitative data. So they see the curve, just like how you see from the blood drawing, how it's changing, but you see that every day, and you can pinpoint to your ovulation or so on. So then just this little change, and then we did try to direct it to consumer, and it was really a big success. Obviously, there's the long story short. Don't want to talk about how the growth happened. There's an entire world about marketing whatsoever. But I think the product itself has to fit a pain point. And the market you're going to, you have to really know the market, know your consumer, who is your clients, right? Who is gonna pay for this? And if there's multiple players in there making a decision, you have to make sure your business model really fit all their needs. And that's the time you can try. And then from there, I think another even safer strategy is like you probably can try multiple different approaches. Don't just hand on one tree. What if that's not gonna work, right? So you can try multiple approaches. You can try different platform or different acquisition strategy, or like even different people to help you, or different ask channel whatsoever, and to see which one gonna work. This test and the trial process, I don't know how much I can emphasize this enough. It's never been, because you can have a fantastic consultant in the market to tell you this is the way to go to the market, but the real story is every product is so different, every market is so different. If you don't try, nobody in this world will ever know this product gonna pick up or not. Never know until you try. So try that and really fail fast, adjust fast if something doesn't work, and then you will find a path to go. It's a long answer, but I think that's basically what I went through. Yeah.
I would say the technology that we adopted was ahead of the game. We came up with asynchronous telemedicine before COVID. And when COVID hit, that helped us a lot because people understood telemedicine, people were used to asynchronous learning, so we didn't have to explain that. And where we're going in the future is, as a woman of color, I realize that what we're teaching at the major medical schools, we teach everybody, try this birth control pill, and if that doesn't work, then use this one. And I spoke to my fellow Asian, fellow Black, fellow Latina doctors, and we're like, oh yeah, that pill we're telling to prescribe everyone does not work for our people. And I was like, oh yeah, I had to go through 3 different birth control pills until I found one that didn't have a side effect. And I've been on birth control pills for like 20 plus years. I kept trying this pill, and as a doctor, I don't have to take a pill every single day, so it's not about compliance or adherence, it's that pill. And so this works great if you're a Caucasian female that wants to bleed every month. But if you're of Asian, Black, or Latino descent, this pill gives us a side effect. So being from MIT, being from UCSF, Stanford, I couldn't just sit there and watch women suffer. I took all 40 different pills, ranked them from most likely to make you bleed, least likely to make you bleed. Most likely give you zits, least likely to give you zits. Most likely give you munchies, least likely to give you munchies. Took the one that we're telling everybody to prescribe, fixed it for the side effect that we're seeing in people of Asian, Black, and Latino descent. And with that, we see 82% of people happy at a year with the first birth control pill or with our company versus 30 to 55%. And so right now, we are the only company, to my knowledge, that has an algorithm based on your age, because I'm adolescent medicine. I want to make sure you have enough estrogen to protect your bones, body mass index to make sure the pill works for you, and then your health history, of course, and then race as a proxy for genetics. But my daughters are going to be half Korean, half Taiwanese. And so they're going to respond differently. If they marry somebody who's Latino, that's going to be a totally different thing. So because we're in Silicon Valley and a lot of people have done 23andMe, Ancestry, etc., we're asking patients, would you give us your DNA? And then we can look at different SNPs and be like, oh, your P450 is this, your androgen receptor is that. And with this combination, this pill does great. There's 40 different pills and we just gotta match the genetics of the pills. So we're gonna run an AI ML model on that. And I did some preliminary research for a talk I had to give in Boston that showed that different ethnicities have different P450s, and it's about drug metabolism, how fast you eat the estrogen, that you get different side effects. And so I absolutely believe the future is personalized medicine. And the sooner we can all get sequenced and contribute our data to science, the better. We're starting with birth control. We certainly can do the same application to acne, the same application to obesity. And the difference between a for-profit company and a research institution, we have some Stanford colleagues in the audience today, is that a Joe Blow physician will write like 5 birth control prescriptions a day. All I've been writing for the past 8 years is birth control prescriptions. We have data on 40,000 women. To get that same number for a clinic, you'd have to collaborate with all these different clinics. And so that's the beauty of a company that's focused on a particular thing. I would also love to, collaborate, because no one has the hormonal data on people going into menopause, and then their levels when they're on HRT, when they're not on HRT. And if we just give them a whole bunch of Sylvia stuff, and then we put them on HRT, which our company does, then we'll have this whole new database.
Yeah, that's very, very exciting. Yeah, and I think we're, so how we start, going back to, Christy's question, is we were looking at, just personally, I was motivated from working in fertility centers. I grew up in Canada, went to medical school at University of Toronto. So I've been in fertility clinics in different places in Canada and the US, and just seeing, no matter where you are, the top question that patients want to know is, what are my chances of having a baby? Depending on what the doctor's recommending, from this treatment or that treatment, just what are the chances this will work? And so and then really going back to using data. At the time, machine learning wasn't yet even talked about to be used in medicine. So it was actually very exciting. I didn't know anything about it when we started. And we were just thinking, let's just put biases aside, let's assume that we don't know anything. And we were an alien coming to Earth, and just figuring out, how could we figure out how to counsel patients about it. And so fast forward, what we have today is really a data-driven way, and the main goal that we want to do is to break down this information asymmetry. It's not just information asymmetry between patients and providers. Even among providers, they don't actually realize which patients might have high chances of success. And we have now, really compared to conventional models and conventional ways of counseling to show that most doctors are actually underestimating the chance of success of their patients. And this actually can be harmful, because in a situation where payers are always looking for excuses not to fund a treatment, underestimating the prognosis for some patients is actually not helpful at all. And so we want to really try to give this information, give this transparency to payers, providers, and the patients. And we already have real world examples of how this can actually create value-based medicine, and more patients can actually afford going through multiple treatments, which is the way to maximize the chance of having a baby, at least based on the technology today. So that's kind of what we're working on. But you know, that I think there's great opportunity to use the technology platform that we've developed to apply, to really advance precision medicine and bring precision medicine to fertility, including using genomic medicine and so on. And so those are areas that we're working on and very interested in.
Awesome. So we've talked about innovation from a variety of different perspectives. I think it's important when we think about women's health to become comfortable with being a little bit uncomfortable. And so what I mean by that is, I grew up in a conservative home. Did we talk about birth control? I'm not saying that's good or bad or otherwise. I'm just saying that's a fact of my background. And so, you know, when you're not talking about a variety of topics, whether it be birth control or otherwise, or IVF or freezing your eggs, there are a lot of myths that can, let's face it, become perpetuated. So let's talk about some myths as it relates to IVF or fertility. We can go ahead and start with Mylene, if you want to start with that. And then encourage the audience. Feel free to raise your hand, participate. If there's a myth that you'd like to debunk or talk about, let's go ahead with talking about it, whether you capture it here or you just raise your hand and we go ahead and communicate it to the panel. Mylene, would you like to start?
Sure. I'll give, I think the most common myth that we encounter in the field of fertility, there are actually two extremes, and they're both very common. One is really people saying, oh, I don't need to worry about having a family now. Technology is great. I'm just gonna wait till later because technology will take care of it. And they have this perception that IVF can just, you know, do anything. So on the one hand, we have such a myth, but then not a lot of people are not realizing the limitations of technology, at least today. And then on the other hand, we have a completely opposite myth that is as popular. Thinking, oh, well, I'm already kind of older, you know, maybe I'm 38, 39, and my friend's IVF didn't work out, so I don't really think it's worthwhile to pursue. I think I'm just gonna not think about it, even though I would really like to have children. And they, you know, and people who have this perception, they're not even feeling like they might want to go see a doctor just to get checked, just to check out what is their exact chances. So we're seeing both ends of the spectrum, yeah. And I think that's where the personalization comes in. Everyone is basing their understanding on someone they knew, and if that person had a good experience or that person had a bad experience, they think that's what's gonna happen to them, when in fact, you should really go and find out, you know, based on your own health situation, what it really means.
That is, and Sophia, you know, you mentioned birth control, right? I mean, you walk into a store, or let it be your OBGYN, it's like, here are the many different options, right? It's super confusing, lots of impact on mood swings, and this gumption that, you know, if and when you're on birth control, and maybe you're planning for the future, the minute you get off of it, can you not get pregnant, right? There's a lot of misconceptions and taboos. Share with us your perspective.
The top 3 myths about birth control. One is that it makes you sterile. And my joke is, while you're on it, because that's why you're taking it, right? But most birth control, hormonal birth control, pill, patch, ring, implant, IUD with hormone, as soon as it's out of your body, anybody who's taken biochemistry, 3 half-lives later, it's out. So it's out of your body by 1 week. If you want to be really anal, it's out of your body by 2 weeks. The only one that lingers is Depo-Provera, because you stick it intramuscularly, it lives in there in this lipid situation. So it could take up to 8 months for Depo-Provera to wash out, but there's no long-term effect on your fertility of any of the hormonal birth control or the IUD or the implant or the shots, any of that. The second one is that birth control gives you zits. Anything with ethinyl estradiol actually increases your sex hormone binding globulin, which then connects with the testosterone, decreases testosterone, which causes zits. So if you can decrease testosterone, you can decrease zits. And then there's different progesterones, and certainly there's 8 different progesterones. That's my public service announcement for today. And there are 40 different birth control pills. So if you know somebody, they tried the pill, like, the pill sucks, I had these side effects. Did you try the other 7 progesterones? But in general, everybody's acne gets better because of the ethinyl estradiol that binds the testosterone because of the increased sex hormone binding globulin. But if you take a particular pill and you notice you get more zits, then there are 7 other progesterones that you can try. Please try some of the others, and our company has the list of which one is most likely or least likely to give you the zits on the birth control pill. And then third is makes you gain weight. So the research has shown if you have 100 people that are on the birth control pill, 100 people that are not on the birth control pill, the people not on the birth control pill average a pound more. More than the people on the pill. Because the people not on the birth control pill blowed up, blowed down, blowed up, blowed down. So on average, they blowed up a pound. And if you follow both groups over time, Americans in general, we gain weight. And so like, oh, I was on a birth control pill and I was like 110 pounds, and then 10 years later I was 120, 130. It wasn't the birth control, it was America. And then the other myth, I have my favorite menopause books over there in order of preference. Estrogen Matters is a key book for anybody approaching menopause, anybody who's afraid of estrogen. The summary of the book is the Women's Health Initiative, which was a study done with conjugated equine estrogen, which is different from the current standard of hormone replacement therapy, which is bioidentical estrogen. And the average age of the person in that study was 62 years old. And we now know you want to get your estrogen back as soon as possible, at least within 10 years. So many flaws to that study that took us back 20 years. Because before we were just doling out hormone replacement therapy, and then they had this study, and then we all stopped it, and it just took us all back. And so very few women, a lot of women are confused, a lot of physicians are confused. That book is written by an oncologist, and it's really the progesterone that's causing the breast cancer and not the estrogen and synthetic progesterone. We have not, to my knowledge, seen a case of breast cancer on the bioidentical progesterone, which is what we're currently doing for HRT. And then the other 2 are general menopause books, and the last one, I am very interested in dementia, and there's the recent research showing that those who have ApoE, and I forget if it's 3 or 4, somebody who knows, tell me, which one's the bad one? 4. 25% of the population has ApoE4, but only 10% will get dementia. But if you're on estrogen, you have a decreased risk. And so, as I like to say, I love alliteration: blood, bone, brain. But technically, there's only 4 indications for estrogen right now, just so you all know. Hot flashes, night sweats, genitourinary symptoms, so what I call sandpaper vagina or painful sex, and recurrent urinary tract infections. And then lastly, as a minority, we're always like, life sucks and they don't give us good enough health care, but for once, just being a minority, you qualify for risk of osteoporosis, osteopenia. So that is if you have a family history, or if you're at risk, if you're lactose intolerant, if you don't feel you've got enough calcium in your life, we instantly qualify for HRT. But currently you do not qualify for cardiac, you do not qualify for brain, and my question to the societies that are out there is like, well, how much research do you need until we can say we can use it for prevention of cardiac, we can use it for prevention of brain? Because I feel the whole reason we started HRT to begin with was for the heart. And so I think have more than enough data, but it's not one of the current indications.
And Sylvia, before we talk about hormonal health, I think we have a question from the audience. Yeah.
The question about the IVF is that before you go to IVF, this is my personal experience, this hormonal therapy where you have to get up at 4 in the morning and try. Does your program help to decide whether going that route is also effective before you move to IVF, so don't waste a lot of time and money trying that before you move?
Yeah, so actually so that is something that, your provider should be making the actual diagnosis. And one way, actually Sylvia mentioned this as well, what is really not good is when patients are being just asked to, just try on your own, just keep trying, whatever. And everybody needs a plan. Maybe everyone's plan is not the same because everyone's goal is not the same. some people may have more tolerance for waiting longer before doing something more intrusive. Some people just want to be pregnant like today. I don't care how intrusive it is. So I think in a situation like that, what providers really, what they do, and they do try to do this, but it's very difficult without a prognosis tool, is to say, given this patient's situation, how long is it reasonable for them to try on their own or move to the next step? And also, by waiting, is this person now gonna be compromised? Because if they wait X number of months and now they still aren't pregnant and now they do IVF, have they now been compromised because of all that time waiting? And so those are the things that we're working on, like to help people make the decision or know the trade-offs. Everybody is going to be different. Some patients will say, oh, if I only have a 30% chance of having a baby from IVF, that's not worth it. That sounds way too low. But for others, they may say, okay, I wanna try that. Or I'm willing to try this 3 times because it's like flipping a coin. If you can flip a coin 3 times, there's a greater chance to get heads. I mean, you're all from MIT, so you get this. But if you tell everybody you can only flip the coin once, well, that becomes really high stakes, and that it really drives up the anxiety. But the difficult thing, I think, for patients is that not unlike the coin, not everybody has 50-50. Some people have 70-30. Some people have 20-80. And if you don't know your coin, you can't really decide what is right for you, how many times to flip it, or how much money to put on it. So that's the kind of thing that that's the information we want to give to people. Like, do you want to flip this coin? How many times do you want to flip it? How much money are you willing to put in that coin?
Any other questions? Okay. So Sylvia, talk to us about hormones, because whether someone's in their 20s, 30s, 40s, like when should we be testing our hormones out to understand outcomes or better health outcomes? And then tell us some myths that you want to share.
Yeah,
Sorry,
sure.
that was my question to you.
Yeah, sure. I will answer both. Yeah. So regarding the myths, I think the biggest myth I have seen is like we assume we know so much, and we assume we know too much actually, and we actually don't know. So before I started this company, I'm the same thing. And if you're thinking about, okay, I'm gonna go to trying to conceive, and I try, and maybe I'll say OB and say, oh, do this assessment. So that's great, and I see my hormone over there. But what you don't say is like those things are like very general. It's like we're talking about population average almost all the time. However, if you look at individual data, nobody's at the average. Average means 50% people above that, 50% people below that. So who is really over there? And I didn't say this until I found Emira, and I started to see the backend data for our consumers. I initially when I started, I have to learn this, right? I'm not a doctor, so I went to Wikipedia and I saw, okay, LH, great. So that's the ovulation hormone. So you're gonna search on day 14. So the 28-day cycle, and that's really great. It's a really big peak. We can measure that. Here's a cutoff. There's even a universal standard cutoff, like I think it was 10 something. If you're above that, it's called a positive. Otherwise negative. And then we developed the product and we started to test with our users. And you see really crazy things. Like some people only got 5, and that's their peak. Only got like really high, like 50 whatsoever. And then later I realized LH is actually easy hormone. If you think about estrogen, even that baseline, my estrogen baseline, when I measure with Mira, probably 330. And my colleague, another really early like team member, she measured like average like 300. That's a baseline. It's a 10 times difference. So then doesn't mention about even your peak and late, early, and this is just inter-woman variability, and it's not talking about inter-cycle variability either. So, and we're not even talking about how your life can affect this, right? So your life is not like a stable line, it fluctuates too. You got stress, you get busy, you don't sleep well, whatsoever. So then, I suddenly started to realize, I think we assume too much in hormonal health. We probably assume too much in women's health in general. We think we already knew. And I think our medical is, medicine is so advanced already. We can treat this, we can deliver baby. There's not much issue. And until you start to work on hormonal health, and they feel like we don't know anything. Seriously, we don't know anything. So we just know the average. So that goes back to what you guys were talking earlier. I think one key here thing is like a personalized medicine is really, really important in women's health. Because women's, I'm just talking about hormone, that thing is so personalized. It's so different, everyone, at any given time, any cycle, it's all different. And that variable, nobody understands the correlation, like what really affects this. Maybe there are multiple factors that affect this, maybe single factor, we don't know. However, there should be some research going into here to understand, what is roughly the pattern, or even we don't know the cause, but we can know the correlation, and there can be many, many business models being developed based on this correlation, and that can help people. So we should really go into personalized medicine in women's health, given the lack of research, lack of data in the past, and then and really treat them individually, treat the individual situation, individual person situation, talk with them, and I think that's probably the biggest thing, I have seen since I started Mira. Like I used to not know, and now I realized that, this is really, really different. And just to answer that question about the hormonal health, yes, so hormonal health is something you probably want to monitor for your entire life. If you're a woman, probably guy as well, right? So they have hormone as well. Yeah, so it's not just the time, not just the time when you're trying to conceive, because your body works as a whole thing. So hormones, I'm not a doctor, but hormone really affects your day-to-day life, like your skin and how you feel, your mood. And we did some really interesting consumer research because we have so many consumers, and we found, women feel different for themselves at the follicular phase compared to luteal phase. Usually people like themselves better when they're in follicular phase before ovulation. Everyone feel like my skin is better, I look better. However, when you go to luteal phase, and I don't like the mirror, myself in the mirror whatsoever. And there's also some research done about productivity, when are you most productive? And when you feel the best and whatsoever. So there's a lot of stuff affecting, how your hormone change affect your life. I know those things will need deeper research and to truly understand, but I want everyone to respect their hormone levels. It's not something you only need that when you're trying to conceive or go into menopause. You need to understand that all the time. That really regulates your life.
We have a question that came in that I just took notice of. I think it's a really important topic, so I want to make sure we amplify that question. In the spirit of reproductive health and mental health, the question that arose was postpartum mental health. I don't know, I think it was Divya in the audience. Yes, would you like to?
Yeah, so thank you. My name is Divya, and I work in the mental health space, and I'm so curious, what work have you done or has been done in general in terms of reproductive health and mental health in the postpartum time frame? Because I think postpartum depression is so serious, and it's not something we're often, that intersection of women's health and mental health are just tricky spaces to talk about in the public eye, and I'm so curious as to your opinion on them.
I'll start and then I'll hand it to the OB-GYN. I'm not OB-GYN, I'm adolescent medicine. I went into adolescent medicine because I didn't have to deliver babies, but I could still do the pelvic exam and write birth control. But speaking from personal experience, and anybody who has ever birthed a child and then had to breastfeed, I thought that residency was the worst part of my life, which is pulling an all-nighter every fourth night for 3 years in a row, and that was pretty horrific. But breastfeeding is every 2 to 3 hours for 3 months solid. So anybody without a uterus in this room who has never breastfed, just imagine some annoying alarm going off every 2 to 3 hours, and then it's your child and it's crying, and if you don't feed it, you feel a ton of guilt. And then after like 3 months of maternity leave, all I did for 3 months was talk to my child, Bear. I forget, it was all farm animals. I was like, when is this ever going to be useful in my child's life? Farm animals and jungle animals. And after 3 months of that, I couldn't form a sentence. And so I had to go back to work. No, duh, there's maternal depression. How come no one noticed this before? I think sleep deprivation is a huge component of it. But in terms of technology addressing it, there are definitely a lot of pre and postpartum support companies that are out there. Our company is not doing that because there's so many companies out there. We're happy to refer. Once you get pregnant, they'll follow you before and after. And I just spoke to a company that's doing CBT for insomnia and specifically postpartum depression as well as menopause. So there are a couple of mental health companies because it's really hard to see a mental health provider and access it. But
yeah, so Sophia, I think you describe it like really just perfectly. And I guess maybe what I can say about postpartum depression or other mental conditions is that, first of all, this is really the crux of the problem. A condition like that we really know very little about it. And yes, I'm glad that more companies or more providers are aware to now be more alerted, and even like there are apps that can give you red flags or when you need to pay more attention to people that are saying, I'm tired, because you know, in the past, or maybe even still now, very easy for a woman to get her complaints dismissed because, oh, you're just tired like all the other moms. Of course you're gonna be tired. And that's a very dangerous thing to, for people to kind of miss a diagnosis, miss the opportunity. But the big problem is that this kind of, this area has been so poorly funded by the NIH. So what the problem, for decades, right? So, and we're talking about, and I've talked to some companies that are trying to address this in their platform. But what a company needs to do to address that fully is kind of what we've all gone through, is you have to create that data set from scratch. It's not like if you're a cardiac medical device or cardiac therapeutics, that you have decades of high quality data to rely on that have been invested by NIH. And now you can already know so much, and yes, you can go and continue to innovate. For all of these companies, there is not even a data set when they first start. They basically have to build it from scratch, use investors' money to build that data set. And so the challenges are just really huge, but I'm really excited to see that many companies are still doing that and trying. But I think at some point, and this recently, this funding that became available, hopefully we'll be able to address that. But I think it's still not enough. Even looking at, I attended some of the webcasts of how that money is going to be used, how the funding works. It's really important and we need it, but we need so much more. It's just, the tip of the iceberg. So I don't know exactly what are all this, what we can do, but there, I really hope that we come up with a better way to have massive amount of funding, so that we can create the data sets to be able to address mental health conditions and others. Yeah.
Did that address your question? Did you?
I just want to add one more thing. So I completely agree. I think, but looking at from another angle, so we do mostly directly to consumers. So we see that there's many actually creative solutions for those kind of problems from the consumer-driven companies, or like a marketing company or like an app company. So there's many apps addressing, I think, postpartum depression or like mental health, specifically for that period of life. Like even for us, we have the meditation class for trying to conceive stage. So so they're different. Again, this is because we lack of data. We shouldn't treat this. Every stage in women's life is the same. We just need one meditation app and that will work for everyone. It's not. So there are many companies out there and startup companies really trying to solve this from their own angle. I think this is really great. It's not gonna replace that funding. It's not gonna solve that issue. I don't think that funding will be sufficient. But on the other side, if we're a consumer, really need some help, and maybe you can look at, see what are the solutions out there. Sometimes, I know there's lack of data, those solutions may not be addressing the root cause or like a cure that, but it will be some help out there, better than nothing.
Awesome. Well, yes, question.
I have a question. Mylene, with all of the data you're collecting for IVF, are you also collecting data on, for lack of a better word, natural ways of doing your non-intervention from IVF? And I'll just give one anecdote, because to sort of put this, a family member trying for 7 years, really stressed out. And so mother-in-law says, we can fix this, and gives this woman a neurotic, purebred German Shepherd. It took 2 months, and she was pregnant. So I'm just interested if there's like those, so, I mean, it was one of those, she stopped focusing and relaxed, but there's clearly something about, the sort of, Mira's data and hormonal and what have you. There's something, but I was just curious if that's something you're looking at as well.
So, yeah, I think you're definitely right. I think that's where we really need, not just having different types of data being tracked, but somehow for them to come together. Because right now, there is definitely, I mean, even putting companies aside, even in academic medicine, the data is so siloed. You have the IVF data. Even in the same institution, you have the pre-IVF, the fertility data, and they don't talk to each other. And also, there's no longitudinal follow-up of the patient, because it is difficult, but it's not insurmountable with HIPAA and privacy laws. How do you keep track of the same person through life? And this is actually something really interesting. Like, at some point, we should be able to map out the data. Like, maybe we should do a reunion every year or something like this, and figure out like how this actually works. Because ideally, you should really have the teenager should be, using Sophia's platform, figuring out the right kind of birth control or other things, in that stage. And then as they go through life, trying to have baby, use the Mira Health. And then if they don't conceive, now they go to IVF, use the uniform platform, and then later go back to menopause. We don't have that longitudinal data right now, but hopefully we will. I mean, I think that's what we're trying to build towards. But I think also we need some creative solutions in the marketplace, not just from the consumers, but I think has to do with how do we do that if we have different investors? This is a very practical problem, right? And each company needs to work on their valuation. How do there should be, we should find a creative way that companies can continue to build and expand and have valuation. Of course, partnerships is what makes it happen. But right now, the partnerships are usually work out between a big pharma and a smaller company. And big pharma is, in women's health, not contributing to any of this. Okay, if they were, we wouldn't be all trying to create our own data set. The big pharma that has money, that is selling stuff, the manufacturers, they have the ability to do this, but without, because they're not participating, each small company is trying to build things from scratch. So hopefully, we need to have our companies be successful, get that great valuation, get that great exit, and reinvest back. And that's how this is going to work. But it goes back to, women founders being, really, and women's health companies being vastly underfunded. And we're just seeing barriers every step of the way. So we just need to crack that nut, and we need everyone to care about it.
Yeah, and to double click, pharma does play a role. The topic that they do focus on is ED, right? Known as erectile dysfunction. Not to be funny, statistically it's true, the data shows that. You hit the nail on the head, Milan, from the standpoint of whoever owns the cloud capital rules, and by that I mean access to the data. And the fact that a lot of startups cannot collaborate on the data, whether that be via proxy because of who they're funded by or otherwise, we really need to create an ecosystem where you can get access to data. That's the only way you're going to be able to access that longitudinal. I know we're cutting short on time, and so, would you like to ask a question?
Yeah,
yes,
question.
Please.
So this is kind of a silly question, but you're talking about data and different interdisciplinary relationships. Like, between fertility and mental health. So has there been any, do you guys do any studies between nutrition and lifestyle and fertility? For example, you know, biochemistry, you know, hormones are based on cholesterol, and there's pressure from doctors for people to have low cholesterol. And normally, you know, for most people it doesn't really matter, but you know, you may have women who are anorexic or maybe they're athletes and they work out too hard and it may affect their cycles and fertility, things like that. So is there any studies on, or like, you know, people are vegetarian or whatever, but I'm just curious if there's any studies on between those two things, nutrition and.
I think there's a lot of data with ED and nutrition, especially where underweight is concerned, and also obesity is concerned. So there is, but I think still it's really not in the way that we would like to be able to tie together to help an individual. What does that individual do, right? Like, yes, there's this study and it tells you, you know, how you can be affected because of your weight, but what is that person supposed to do today to improve their situation? We're not there yet.
Yeah, just to add on that, so there are a lot of studies. So there's university reaching out to us to understand, like exactly as you said, like aspects how exercise and training affecting their hormone. Even we got an interest about, you know, they want to send female astronauts to you know, outer space, and they want to track the hormone over there. So there are a lot of interesting topic about this. But the problem is, like just as Mylene said, so it's not an ecosystem. So yes, there's research happening here and there, but think about from a company perspective, right? So women's health company, we not only have to develop the product, we have to do research as well. And you have to, you know, collect your data. There's no data, you collect your data. You're also trying to invent how this data could be useful. We talk with many pharmaceutical companies as well. Most of them, even looking at the data, they don't know what to do. I think many, you know, similar companies did that too. So it's like you know, I think it needs a push from every angle. That NIH funding needs to be more, and the Biden funding needs to be more, and the university needs to do more research. Probably there needs to be a grant or something to, you know, focus on specific women's health function or like a disease. Really try to do research from top down, and really that will transfer to be something like, okay, you have research and now you can transfer to clinical and you can train doctor what to do. Eventually will be applied to the consumer. So it's a long journey. But I think on the other hand, at the same time, each of us here as consumer, or, you know, you try to care more for yourself, maybe you're even trying to fund a women's health company, or you're working for a women's health company, we're making that change as well, right? So that's how things will happen. It's a grassroots. We just have to go that way.
I was just gonna add that some of the data isn't being collected. If you go to your general doctor's office, most physicians aren't asking you what you're eating. In my obesity clinic, we always do a 24-hour recall, but we're just free typing. It isn't in a field that's easily extractable. You have to have somebody who knows. MIT people, of course, would know, but it'd be a lot harder to go into the medical chart and pull out the nutrition. And it's not consistent. It's not at every visit. It'd be just easier if there was a form and we filled it in. But that's not the way that doctors do things. We just run our notes and we may or may not ask. Some days I remember to ask about liquid calories, some days I don't. So nutrition particularly, I don't think the data is there unless someone's like, I'm doing a study and here's a, you know, item and you gotta fill out all of that stuff. So I think it's really important. And then the other part is I believe in national health care. I believe in more government, because if the government funded us, the government could force us to share our data. But because we have investors, does my investor want me sharing my algorithm with anyone else? No. My investor wants me to own the entire country, and we are proud that we bring birth control and our algorithm to where we have internet and a mailbox in 16 states, but there are the other states that we don't reach. And if I were to share my algorithm, my company would not be happy about that. The other thing I wanted to bring up is just make sure the quality of the data. So I had a bunch of bright-eyed, bushy-tailed Stanford MBA students, and they're like, oh, we have all of this data from like a national data set of all these physicians, and we're gonna come up with the best birth control pill for polycystic ovarian syndrome. And anybody in academic, OB-GYN, or writing birth control knows that you do not write a triphasic birth control pill because there's just no point to it. It's better just to have a flat hormone and drop or just keep going. And what did the algorithm come up with as the second best birth control pill? A triphasic, because if you train it on crap data, you're gonna get a crap answer. And most physicians are not academic. Most physicians have not been practicing according to what we're teaching at the major medical institutions. But again, I'm proud that we're bringing better than academic care to wherever you have internet and mailbox, even Kansas or Alabama or Florida or whatever. But again, you have to be careful the data you train, and particularly as an Asian is a wastebasket. We know that South Asians have low HDL. We know the Japanese have a high HDL, and if you throw us all together, we're gonna average out normal. We need to treat each group differently, and so I beg of you, if you're all analyzing, categorizing data, please break it by the subcategory of Asian, but the future is really genetics.
Yeah, and to circle back to your question, Jay, because you mentioned athlete nutrition and performance, I didn't dive into Da Vinci and I won't right now. We're focused on that adolescent post-pubescent. There are groups at Stanford and Harvard focused on female triad, red S. These are all deficiencies when your nutrition's off balance with how you're pushing your margins such that you no longer menstruate. Right. And so there is a focal point to what the panel echoed, right? It's intermittent disjoint. There's a lot of headway made in high performance Olympic academies where you're pushing those margins. Yeah. How that translates and correlates to the everyday individual, which quite frankly, we're all athletes, we all walk and get up, right? So we have a heart rate that rises. That's still unclear, right? So there's different, to your point on like, we can go right to Sophia, and then we can go to Sylvia, and then we can go to Milan. It's not always that sequential either. So it's that longitudinal lack.
That's what I was getting at.
Yeah, just to circle back. Sorry, I don't know your name. I don't see your name. Apologies. Yeah.
Hi. So there's many girls and women who have lots of personal barriers to receiving reproductive health care. And so I was wondering how your companies work to reach those women who face cultural or educational barriers to healthcare.
So thank you for giving me the opportunity to, my gift to this world is #periods optional. Anybody who's bleeding every single month with a uterus and who doesn't want to be, that is so 2020. We now have the technology that you don't have to bleed every month. And so the way to pitch it in more conservative places like people who might be going to school in Texas, I know there's at least 2 of you in this audience, this is not birth control. This is estrogen progesterone pill, EPP. We call progesterone only pills POP, and we call birth control pills, or OCP. But really it's estrogen progesterone pill. Really it's hormonal treatment. And my joke is tiger Asian mom in Silicon Valley. Is your daughter gonna do better on the SAT bleeding or not bleeding? Because I was a pre-med, MIT, biochem final, all of a sudden, and I'm like, do I run to the bathroom or to finish the exam? And anybody of you who are pre-med or pre-health, you know the answer. Finish the exam. And I look to my left, I look to my right, MIT. 2 people without uteruses. Not a care in the world. And so I give my daughters the opportunity to make #periods optional, and they will be crushing all of y'all daughters if your daughters are randomly hit with blood 1 week out of 4. As a feminist, I like to say I can do anything you do bleeding, but as a doctor who believes in drugs and science, why the hell would I do that if I had drugs and science? So one way is that this is not for birth control. This is for menstrual regulation. This is for competitive edge. They've actually shown that if you go on the birth control pill patch or ring for 5 years, it decreases your risk of ovarian cancer by 50%. There's no other way to decrease your chance of ovarian cancer other than taking out your ovaries, which I wouldn't suggest you do until they're gonna take out, if they're gonna take out something else and they're there anyway. And it also decreases your risk of endometrial colorectal cancer, and it decreases your risk of anemia. The #1 cause of anemia in a menstruating woman is menstruation. That is a question we pimp all medical students when they go in our OB-GYN rotation. And we have many people working across the world on menstrual poverty because these young people, the #1 cause of missed school and work under the age of 25 is bad evil periods. And if we take out bad evil periods, then people can go to school, people can go to work, people can participate in religion. Women are banned from going to religious institutions in other countries during that time of month. And so, particularly in low-income countries, they can't go to school. And so I've seen in the United States, low-income people, they will miss 2 to 5 days of school every single month. And you're like, oh, it's just 2 days a month, you know, that time of the month. That's 10% of her education. And again, Tiger Asian mom, 10% of her education, that's an A-. Even if she gets 100%, she will never get straight A's. That's not okay. But also, I like to picture education as this wall of cheese. And if I punch out 10%, punch out 10%, punch out 10%, and then I put pressure on the system, it's gonna collapse. And that is the disadvantage of having random blood 1 week out of 4. So one way is you're not doing it for birth control, you're doing it to compete, you're doing it to decrease cancer, you're doing it so you can go to school. It's also good for acne, and they've actually shown having a stable hormone rather than up and down, up and down, up and down. And so I advocate skipping the placebo week because it's 3 weeks and then drop. But better just to be smooth is better for asthma, is better for headaches, is better for diabetes. It's just any chronic disease, it's a lot easier to play when it's smooth than up and down, up and down, up and down every month. And I have a TEDx talk, Google Dr. Yen TEDx, but also I have a little card over there with little panties on it that on the back at the bottom of pandiahealth.com/periods optional is my TEDx talk on the science and safety of not bleeding every single month. She's got the card, you can see. And there's also cuterus stickers back there and pens and nail files. But the other thing is we are in every state, because I'm adolescent medicine, very aware of the laws for adolescents have the right in California at any age to the prevention, diagnosis, and treatment of pregnancy. But we check the laws of each state we roll out in, and specifically I can cite Florida and Texas. If you're under 18 and you're coming to us, then we're like, sorry, you have to go talk to your parent. And we hope that you could push periods optional or acne or bad evil cramps or something.
Yeah, so I think we need to help women to be able to talk about their health better. So that's what we do at Mira as well. So we have so many user stories, and one study we have done was like to understand if women has been gaslighting by the society or by medical professional to talk about their symptoms. And the answer came back, like we did a lot of survey, and answer came back is very strong. So women tend to be treated by, if you talk to doctors, say, oh, I have this problem, and you're not being tended to be treated seriously. And say, I have this pain, but this pain, and say, oh yeah, you're just being emotional, you're just overreacting, and they don't really trust. So it's not just on the medical treatment. I think in general, there's the concern in that way, but this kind of things has been rarely discussed. And another thing we found is like women need more tools to help them to communicate with a healthcare doctor. So, such as imagine if you have data like Mira and say, I see my whole cycle and this is what's going on, and you can talk much more effectively with your doctor. It will also help your doctor to say, what's really happening in your body, it's like in a personalized way. So that treatment plan and that conversation will be more effective too. So I just want to say that I think there is we just can't ignore this. I think in this today, there's when women talk about their symptom or even just communicate, it's not just they say, oh yes, for example, birth control, we just don't want to talk about this, or I'm infertile, I don't want to talk about this. Not. It's like even when I go there to talk about this, am I really being listened? Am I really being treated fairly? Am I really, is a problem really being addressed? I think even on that part, there's a gap. And obviously, a company like us, we have a lot of, we go directly to consumers. So we have a lot of consumer story, help them to talk about this, and we do, campaigns, we write article, and to voice for those kind of things. We need more for that, but there's definitely it's a gap.
So maybe I'll just comment on, the angle for fertility patients. Related to your question, one problem that really, really kind of worries me is, and many of my colleagues, is that, African American women are really not getting that access, not served by IVF. Many reasons. And even today, is from a data set, I can have excellent data on many issues, on many areas, but race is one area that people don't feel comfortable filling in. The race is optional, and especially self-reported rates. So it is very difficult to study and also to figure out how to really increase the access. Now, but then I'll jump onto the other end. The other extreme is all related to this concept that people have. So even when I pitch to some investors or I talk to different people, I've actually had the comment many times. There are certain investors that they actually want to invest in health technologies to expand access, to decrease health inequities, for example. But they'll say to me, oh, IVF is for rich people. We don't want to invest in that. And I was like, well, this is exactly what we're trying to do. It shouldn't be for rich people, right? But we need funding to get that technology and to build the affordability. But even investors who are so focused on healthcare access still somehow conceptually don't get this. There's such kind of a mental block for so many people when it comes to what IVF means. People feel like it's for the privileged people, but it shouldn't be. And so there are all kinds of kind of misperceptions that we're still trying to work on. Yeah.
I think we have a couple more questions. Yeah.
This is kind of back to your original comments. I was wondering, in other countries with national healthcare systems, let's say UK with NHS and Taiwan, are there companies or just the governments themselves collecting better data and being able to have these data sets for either themselves or companies to develop technologies for healthcare in general? And does that put the United States at competitive disadvantage?
Yeah, so I think Reynolds over here saying that other countries, obviously when you have national health care, you can make everybody do something and use a particular system. I don't know. I'm pretty sure everybody's on electronic medical records, but I'm sure there are places where there are not. And there's always an opportunity. I had hoped when the iPad came out that this was an opportunity for physicians to adopt new technology and that Apple or Google would make a better EMR, but no. We're still stuck with Epic and so.
I think in many areas, there is a huge advantage for countries that have a universal healthcare system. But I think, so for example, if you're talking about cardiology or cancer, I think there's definitely a huge advantage. But again, when it comes to women's health, it is the lowest priority, even for but even for countries, I'm even surprised, this is something I'm working on currently. And I would really love if people who are knowledgeable about this. I'm really trying to learn more, because we are actually even talking to some local governments in EU. You all know that some countries have declining fertility rates. In a few decades, there's going to become an economic issue for those countries. Not enough taxpayers, whatever. And they're trying to really solve that problem. And even there, they didn't realize that there's a way to use data, even though they're paying for the IVF for everyone to use it. But they're paying for it, but they don't realize you can't just throw money at the problem. Even if you're paying for something, you have to guide people to make decisions, because otherwise people are freely making uninformed decisions and spending money, but it doesn't mean more babies are happening or more patients are satisfied. So we're actually working on that front. But I think even in countries you would think their data is still siloed. So even if it's funded by governments, we're still talking to one hospital at a time, because the data is not all put together. As far as IVF, the two countries that have the most sophisticated, mature data sets would be US and UK. We have national registries that have been around for, I don't know, at least about almost 2 decades. So there's a lot of data. But there, we're actually making a head-to-head comparison. If you made a model from the national registry data versus from individual clinics where the local validation is important. Actually, with machine learning, the local wins out. And for the patient, you need to be informed by the patient population in your area. And we find that even in the US, like if you're in the Midwest, South, East Coast, West Coast, population clinical characteristics are very different. Even from metro area to urban suburb, very different. So we're actually taking a very localized approach, but with a global kind of implementation. So machine learning is helping us address some of these questions and maybe make the best use of large data sets and also not excluding institutions with small data sets.
And double clicking though on the concept of there's this competitive advantage, but using my hat of AI data privacy and data security and the ethics associated with that, right? Decentralizing the data. Would anyone like to comment? There's always a double-edged sword, right? So the governance of that, I think, is a second part of your question on competitive advantage. Does anyone want to talk about that?
Well, generally, if it's research at an academic institution, the beautiful thing is they make you run it all through an internal review board. But at a private company, we can do whatever. But also, we don't want to piss off our customer, but we are bound by HIPAA if we are doing medical services, and so therefore we can't share it unless we're coordinating care.
So the data privacy is obviously so important, right? For our business, and just maintaining the credibility and reputation means we're actually needing to be 10 times more conservative and more cautious than allowed by law. Okay, there are things that we could do legally, but we don't. And so, because I think at the end of the day, the providers have to feel confident that when they use our platform, that they know the data is never being used for anything that they didn't give permission to. And of course, anonymization and all of those, rigorously in place. And I think because of that, we are maybe the first company or even the first group to be able to get like multiple private clinics, that are not your name brand big institutions, to come together, and because they don't need to share data, because we can actually analyze and perform very consistent analysis across the board to be able to bring together the findings to represent multiple centers. So that maybe is a new way to do things. You don't have to put all the data together physically in one place to give to somebody, to come up with findings that are relevant for the patients.
We're excited to run it. We're running over time, so I really appreciate the engagement. We love it. One more question and then we'll wrap up, just to be mindful, or two more questions. Yes, please.
Okay, so in the most general, I'll just say it loud. In the most general sense, what's the deal with girls bleeding earlier in life than before? What are the implications for brain development, diabetic complications, because it's a big deal for endocrine system and how that affects diabetes, and fertility and psychology? Like, what? That is a big change. And is it just in the United States, or is it all over the place? What's the story?
So I am adolescent medicine, and our big thing is, when does puberty begin? It's only been shown to have a 6 months difference. The average age of menarche was 12 and a half, and now it's 12. But the general rule of thumb from the eating disorder side is you need to have 22% body fat, and then anecdotally 100 pounds. So given our epidemic of obesity, where 66% of our population is overweight, obese, given the high fructose corn syrup that we're pumping into, and that we as a government are subsidizing, and so I'm also an obesity specialist at Stanford in the weight clinic. So it really is the epidemic of obesity and the epidemic of American fast food. So as we bring McDonald's to the Great Wall of China, as we bring, unfortunately from the Asian side, boba everywhere, then that is the problem. And then its impact on fertility is not so much having a period 6 months earlier, it's just 6 months. And there's variability, but it's really about obesity causing polycystic ovarian syndrome, which then your eggs don't pop out. If your eggs don't pop out, then you can't get pregnant, and then you're gonna need metformin or IVF or both, or birth control to prep you, and then IVF to get the eggs out. So that isn't as much a concern, but absolutely we should be concerned. And certainly there's also like things in our plastic, things in our non-stick pans, things in the environment, probably other endocrine disruptors.
That's good.
Thank you so much. I have a gazillion questions, so I just tried to pick one. Nice to see you, Sophia, in the flesh. after Zoom. So I have a multidisciplinary background, bachelor's in engineering, and then decided to pivot and got my doctorate in integrative bio. So now I'm a professor of kinesiology, exercise science, and metabolism. And the question has nothing to do with any of that, actually, but you guys have talked about data sets and machine learning and personalized medicine, and I would just love to hear your thoughts, maybe you've already done this, on the idea of building digital twins using data sets, but then being able to personalize it in a way so between interperson variability, but then intercycle variability, geographic variability. I mean, this seems to be one of those next waves of technology that is being used in things like sending people to outer space, but maybe another great application is within the question of women's health and how to get to a more accurate answer in a more timely manner using these patches of data. So just thoughts on digital twins.
I have tons of thoughts. So I didn't really want to get into Da Vinci wearables, but suffice to say, there's digital twin in many different places related to performance and women's health. So we're looking at it from the standpoint of tracking cycle from 17 through 34, flipping longevity on its head and saying, well, 50% of all genders have one chronic condition, 25% have more than one. So when you think of chronic condition and disease and better health outcomes, the goal is if you have a goal that you're trying to meet, how does your physiology as a female in relation to your menstrual cycle, whether you're regular, irregular, on birth control or otherwise, reflect your performance goal, which would be projection of that digital twin to be that goal. So short answer to that is there's some work that we're collaborating with Duke University, actually Amanda Rendles is leveraging her high performance computing to assess cardiovascular health, not focused solely on women across gender. Our interest is how do we take wearable data and actually project that, because a lot of, how many people are wearing wearables? Maybe not as many as I expected, but the future is what are you wearing and how does whatever's on your skin telling you more about how to live healthier, better. So be better. That was a long-winded answer, but that's Da Vinci. And that's another session that we'll have. Yeah. Anyone else?
I don't have any. That's a great question. Nothing to add.
Yeah, that's a great question.
Actually,
yeah, let's wrap it up. Yes.
Okay,
Yes.
well,
Let's do it.
thank you very much to our speakers, and as a gesture of appreciation, we always have MIT swag. And now with the summer, these BPA-free insulating cups. Thank you very much. Thank you very much.
Thank you. Thank you.
Keep your drink nice and cold.
Thank you.
And thank you for coming. So I just wanted to say thank you very much for all the volunteers that have helped us get this far this year. It was a tremendous year. We committed to doing an event every month, and we did it. And so now we're wrapping up for the season. Our first event is going to be again in September. I think we're kicking off with an event with kidney care in September, and then AI and sports tech. And so we've got this long lineup of events all planned all the way through next January, actually. And so if you want to volunteer in the digital health track, just reach out to me, reach out to Reynolds, reached out to Serena, Sophia, all active volunteers, Melanie, and we're happy to get you plugged in as well with our events. With that, no, it's just us that's winding down. MIT CNC still has lots more events for the summer, so stay tuned. There's a lot happening with the social track and the other tracks, so follow us as well. Thank you very much. Let me just stop this.